of examples, but one is the skin. And by the way, these cells that are constantly dividing will be hardest hit by anything that interferes with cell division, like chemotherapy. Okay, what happens during S phase? S stands for synthesis, and this is when DNA duplication occurs. Therefore, cells in G2 have twice as much DNA as cells in G1.
To begin this section, we'll talk about the phases of the cell cycle. The most general phases of the cell cycle are interphase and mitosis, where interphase is basically growth of the cell, and mitosis is its division. Let's start with interphase, which itself has three parts, G1, S, and G2. So what does a cell need to do during interphase? One of the main limiting factors of cell division is how fast it can grow, since it can't divide until it gets big enough. And what limits how fast a cell can grow? Mostly the amount of ribosomes it has, since cell mass is mostly dependent on the abundance of proteins, and proteins are made by ribosomes. This growth happens during G1, which is the longest phase of the cell cycle. This is also the only time that cells can exit the cell cycle to enter G0 phase, in which they are not dividing. Some cells in G0 are still capable of dividing when stimulated to do so, and can re-enter the cell cycle in G1, such as fibroblasts, hepatocytes, and lymphocytes like this one here. Cells can also leave the cell cycle during G1 to become terminally differentiated, such as neurons like these, or muscle cells or erythrocytes, which will never divide again. Once cells transition into S phase, they're committed to complete the cycle, so S, G2, and mitosis progress much more rapidly. What's an example of a tissue that has cells that are constantly proliferating? There's a bunch of examples, but one is the skin. And by the way, these cells that are constantly dividing will be hardest hit by anything that interferes with cell division, like chemotherapy. Okay, what happens during S phase? S stands for synthesis, and this is when DNA duplication occurs. Therefore, cells in G2 have twice as much DNA as cells in G1. In both cases, they have 46 chromosomes, which is 23 pairs of homologous chromosomes, or 46 chromosomes total. But in G2 phase, each chromosome is made of 2 sister chromatids, whereas in G1, each chromosome only has 1 chromatid. Mitosis is the shortest phase of the cell cycle and includes prophase, metaphase, anaphase, and telophase. This is when the chromosomes condense and separate, and one cell becomes 2. After mitosis and cytokinesis, the single parent cell is now 2 daughter cells. So let's talk about regulation of the cell cycle. What happens if a cell cycle is not regulated properly? Well, this can cause cancer. Cells can become neoplastic and form tumors. Therefore, it's really important that there are checkpoints that control transitions between different phases of the cell cycle, so if something is wrong and the cell should not be dividing, it can put on the brakes. One family of proteins that regulate the cell cycle are the cyclins, and the cyclin-dependent kinases. Cyclin-dependent kinases are constitutive, which means they're always around in all phases of the cell cycle, but sometimes they're active and sometimes they're not. So what activates them? This would be the cyclins, which is why they're called cyclin-dependent kinases. The concentration of cyclins fluctuates over time, depending which phase of the cell cycle the cell is in. There are several different cyclins and they're present at different phases of the cell cycle. The cyclins will activate specific CDKs, and the CDKs will then activate other proteins to do whatever needs to be done during that phase of the cell cycle. For example, in S phase, they'll activate proteins to initiate DNA replication. By the way, as a preview to a later part of biochem, what does the kinase in cyclin-dependent kinase mean? This means that they phosphorylate their targets, and phosphorylation is often used to activate or deactivate proteins. Since the G1 phase can last indefinitely, but once cells transition to S phase they're committed to divide, the most important transition to regulate is the G1 to S phase transition. This is why tumor suppressor genes, such as retinoblastoma and P53, are both able to prevent this transition. So what's a tumor suppressor gene? It's a gene whose protein product has a role in preventing cell division, and thus plays a major role in suppressing tumors. Okay, so what might happen to a cell that would make it want to halt the cell cycle? One of the most important things is DNA damage. P53 is one of the most notorious genes for detecting and responding to DNA damage, which has earned it the nickname the guardian of the genome. If P53 notices something wrong with the DNA, it'll prevent the cell from dividing, thus preventing tumors from occurring. When DNA damage is detected, P53 will stop the cell cycle and initiate DNA repair pathways to try to fix the damage. If the cell is able to repair the damage, the cell cycle can restart. However, if it can't, P53 will initiate apoptosis, because it's better for a cell to die than to risk developing cancer. Retinoblastoma, or RB, also prevents the transition from G1 to S phase, but works a bit differently. Basically, RB has a few sites that can be phosphorylated, but after mitosis ends, RB loses most of its phosphate groups. In this hypophosphorylated state, it is active and it's suppressing the G1 to S phase transition. Only when it's inactivated by adding more phosphate groups will it allow the cell cycle to continue. And guess what type of protein adds phosphate groups to RB to allow the cell cycle to continue? That's our friend the cyclin-dependent kinase. Tumor suppressor genes like RB and P53 follow the 2-hit rule. which means that both copies of the tumor suppressor gene have to be mutated to allow neoplastic transformation. This is because if only one copy is mutated, the other one is sufficient to regulate the cell cycle and prevent tumorigenesis. By the way, p53 is so powerful that more than half of all cancers have loss-of-function mutations in p53. Okay, we're going to switch gears now and talk about the different parts of the cell. We'll start with the rough endoplasmic reticulum, or RER. The rough endoplasmic reticulum is endoplasmic reticulum that's covered with ribosomes. This gives it a rough appearance under electron microscopy. Here's a scanning electron micrograph showing some rough ER, and I want to point out that it's generally found near the nucleus, which is this round object here. But it's hard to appreciate the detail from this, so here's an artist's rendering of some more rough ER, and you can see that the smooth ER has no ribosomes, and the rough ER is covered in it. So why would you want ribosomes to be in this membranous structure instead of floating around the cytoplasm? Because the rough ERs where secretory proteins, which are destined to be exported from the cell, and proteins that will end up embedded in the membrane, are synthesized, and it's more efficient to make them all in an organized location instead of trying to round them up later, after they've been in the cytoplasm. The rough ER is also the only place where certain post-translational modifications are added. Can you think of any examples? The main one is end-linked glycosylation, in which a group of sugars, which is called an oligosaccharide, is added to the nitrogen atom of an asparagine amino acid on the protein. So here's our asparagine, and here's the amine and carboxyl groups that all amino acids have. And here's the part that makes asparagine unique, which includes the nitrogen that gets sugars added to it. Why is it called end-linked glycosylation? Because we're adding the sugars to a nitrogen. But you can also use this to help you remember that you're attaching it to asparagine, since this amino acid is represented by the letter N. Okay, so what types of cells do you think might have lots of rough ER? This would be any cell that secretes lots of proteins, so some examples are mucus-producing goblet cells and antibody-secreting plasma cells, like the ones you see here, with their eccentric nuclei to make room for rough ER. And don't forget about neurons. We don't often think about neurons as secretory cells, at least I don't, but in fact they make tons of vesicles filled with peptide neurotransmitters, which they're secreting all the time to send a signal to the next neuron. And by the way, in a neuron, the rough ER is called a Nissl body. Okay, what about the smooth endoplasmic reticulum? How is this different from the rough ER? Well, the smooth ER does not have ribosomes attached to it and has no role in protein synthesis, but it has two main functions, which are steroid synthesis and detoxification of drugs and poisons. What cells produce lots of steroids and therefore have lots of smooth ER? This could be hepatocytes, gonads, and the adrenal cortex. And what about detoxification of poisons? That would also be hepatocytes. There's one more thing you should know about the smooth ER. This is where the protein glucose 6-phosphatase is located. What does glucose 6-phosphatase do? It catalyzes the last step in gluconeogenesis by removing the phosphate from glucose 6-phosphate, which allows it to be exported from the cell. Do you remember the name of the disease that's caused by glucose 6-phosphatase deficiency? This is von Gierke's disease. Alright, time for our first flash quiz of the cellular section. The tumor suppressor genes P53 and RB prevent the transition from the blank phase of the cell cycle to the blank phase. So these guys block the G1 to S phase transition, because remember, once you get past that step, the cell is pretty much committed to go through the rest of the cell cycle. Now let's go over cell trafficking, or how proteins are sent to one place or another in the cell. The main character here is the Golgi apparatus, which is kind of like the specialized endoplasmic reticulum, which has some modifications for packaging molecules before they're exported to their final destination. This is a scanning electron micrograph of the Golgi apparatus. Honestly, you'll probably never need to be able to recognize this in your exam, but just in case, you can see here that the Golgi is pretty easy to recognize. It basically looks like a cross-section through a stack of pancakes, and sometimes you can see these vesicles coming off of it. As I mentioned earlier, end-linked glycosylation occurs in the rough ER. However, these end-linked oligosaccharides can be further modified in the Golgi. Also, O-linked glycosylation occurs exclusively in the Golgi, and only occurs on serine and threonine residues. So what's O-linked glycosylation? It's pretty similar to N-linked, except now we're adding the oligosaccharides to an oxygen atom, which is on a serine or threonine amino acid, which is why it's called O-linked. So like before, these are the amine and carboxyl groups that all amino acids have, and here are the oxygen atoms that the O-linked glycosylation will add sugars to. So like I said before, the Golgi is mostly known as the distribution center of the cell. Now how does it know what needs to be sent where? Well, specific modifications on proteins can target them to different organelles, and the most important example of this for exam is that adding mannose 6-phosphate to a protein targets it to the lysosome. So here's mannose 6-phosphate, which is just a mannose sugar with a phosphate group on its 1, 2, 3, 4, 5, 6th carbon. Now if someone is unable to add mannose 6-phosphate to a protein, where are those proteins going to end up instead of the lysosome? Well, they'll be secreted outside the cell, and this results in a disease called eye cell disease. How can you diagnose this? Well, if you see high levels of lysosomal enzymes in the plasma, that's a big clue. Patients with eye cell disease will often have coarse facial features, clouded corneas, and restricted joint movement, and this is usually fatal in childhood. This might show up on a test as a really sick baby with lab results showing lysosomal enzymes in the baby's blood, and they ask you which of the following mechanisms is responsible for the disease, and of course you'll pick the one about not being able to add a sugar to a protein. Now, not only can the Golgi add sugars to proteins, but it's also important for assembling proteoglycans, which are proteins that have lots of polysaccharide chains attached to them. These are often secreted into the extracellular matrix, and used as a cushioning filler substance. So where do you think you might find it? Well, there's lots of proteoglycans in cartilage and in joints, and one of the main ones is chondroitin sulfate, which, as you can tell from the chondro in the name, like chondrocyte, is an important part of cartilage, and people even take this as a dietary supplement for osteoarthritis, although I think the jury is still out on whether or not it actually helps. Lastly, the Golgi is where many post-translational modifications are added to both proteins and proteoglycans, such as sulfation of tyrosines on some proteins. So now let's talk a bit more about vesicular transport to and from the Golgi. The Golgi is found between the rough ER and the cell membrane. And the cis Golgi is what we call the side close to the rough ER, and the trans Golgi is what we call the side close to the plasma membrane. There are three main proteins that organize traffic to and from the Golgi, as well as between the different layers. COP1, which stands for coat protein 1, is involved in retrograde transport from the Golgi back towards the ER. It's also used to bring things from the trans Golgi back towards the cis Golgi. So basically everything in this downward direction. Now COP2, or coat protein 2, does just the opposite. This causes anterograde transport from the rough ER towards the Golgi, although this one does not have a role in transport from one part of the Golgi to the other, like COP1 did. Now you might have your own way of remembering these, but I like to think of it as 1 being symbolic of the beginning, like the starting point, so COP1 goes towards the beginning, which in this case is the rough ER, and COP2 goes the other way. Lastly, clathrin is important for receptor-mediated endocytosis, and is also used to send vesicles to lysosomes. When something is endocytosed from the extracellular environment, it's first stored and handled in a temporary organelle called an endosome. Depending on what the endosome contains, it can be sent to a lysosome for degradation, or to the Golgi for more processing, or even back to the membrane for excretion. Peroxisomes are the organelles where catabolism of very long-chain fatty acids, like this one, begins through the process of beta oxidation. This converts them into medium-chain fatty acids by removing pairs of carbons as acetylcoenzyme A. And the medium-chain fatty acids are then transported into mitochondria and completely degraded, which will be discussed more later in the chapter. So if a patient has dysfunctional peroxisomes, what happens? The main problem is that long-chain fatty acids accumulate, both in tissues and in blood, and can cause neurologic defects. This is called Zellweger syndrome, and it's autosomal recessive. These patients will have defects in neuronal migration and hypomyelination by the time they're born, and after birth can lose hearing and vision. So how would you recognize this in a newborn? Hypotonia, seizures, and an inability to eat would be the first clues that something's wrong, and hopefully after further testing you'd see that very long-chain fatty acids accumulating. The proteasome is a large complex of proteins whose function is to degrade other proteins into small fragments about 8 amino acids long. This is a very important function, since misfolded or damaged proteins can cause disease, such as the beta-amyloid proteins in Alzheimer's disease. Proteasomes look kind of like a barrel, and have a regulatory component shown in red, and a catalytic part shown in blue. Since you don't want these things going around degrading all your proteins, cells have a system that allows the proteasome to be selective. So here's a protein that in some cases we might not want to have around, so we want to degrade it. This is the protein Huntingtin, which aggregates and causes Huntington's disease. Proteins that need to be degraded are recognized and then modified by enzymes called ubiquitin ligases, which covalently attach a small protein called ubiquitin to the target protein. Ubiquitin binds to the proteasome's cap, which causes the barrel to open and allow the protein inside, where it is degraded. For our next flash quiz, can you tell me where a protein is going to end up if mannose-6-phosphate is attached to it in the Golgi? That would be in the lysosome, and remember, if this mechanism is defective, you can have eye cell disease. Let's move on to the cytoskeleton. Do you remember the cytoskeletal elements? We've got microtubules, actin, and intermediate filaments. We call it the cytoskeleton, but it's not just to hold the structure of the cell. It also has roles in transporting things around the cell along microtubules, helping the cell move around using flagella, and even helping the whole body move, since muscle contraction depends on actin and myosin. You can get a sense of how the cytoskeleton is organized by this picture, where the nuclei are blue, the microtubules are green, and actin is red. Actin and myosin compose microfilaments and are the thinnest structure in the cytoskeleton, with a diameter of just 7 nanometers. You probably know that actin and myosin work together in muscle contraction, and that's covered in a different lecture. But can you think of anything else that actin does? It's an important structural component in microvilli. Do you remember where you might find lots of microvilli? One example is the brush border of the small intestine, where microvilli are used to increase surface area and therefore increase absorption. Remember, a villus has a lot of cells, and each cell has lots of microvilli, so microvilli are a lot smaller than a villus. Actin is also used in adherens junctions, which are common in epithelial and endothelial cells, and are used to hold cells together. Intermediate filaments are generally involved in cell structure and have an intermediate diameter of about 10 nanometers. Some examples of intermediate filaments are vimentin, desmin, cytokeratin, glial fibrillary acid proteins, and neurofilaments, but I'll come back to these in a couple minutes. And microtubules are the largest part of the cytoskeleton, with a diameter of about 25 nanometers, and they're generally involved in movement of things within the cell, or of the cells themselves. We see them in cilia and flagella, and also in the mitotic spindle and centrioles. Okay, sorry for jumping around a bit, but we're going to revisit intermediate filaments in the context of histological stains. Glial fibrillary acid protein, or GFAP, is found in neuroglia, such as astrocytes. Neurofilaments are obviously found in neurons, and cytokeratin is found in epithelial cells, which you can remember since epithelial cells in the skin are keratinized. Lastly, desmin is found in muscle tissue, and fomentin is found in connective tissue. There's not much else to say about these, just make sure you know which stain is for which cell type, so when it shows up in your exam it'll be that much easier to answer the question, or at least rule a few answer choices out. Okay, let's talk more about microtubules. What color are they in this image? They're the green ones. They're about 24 nanometers in diameter, which makes them the largest cytoskeletal element. They're cylindrical structures formed by polymerized dimers of alpha and beta tubulin. Each dimer has 2 GTP bound to it. Also remember that they have a positive and a negative end. They grow together in chains, maintaining their polarity. While their growth is relatively slow, they can collapse quickly when needed. So what are microtubules used for? Well, there's really a lot of things. Basically, anytime you want to move something large around a cell, you need to use microtubules. For example, during cell division, what do you want to move around? This would be chromosomes, since you have to separate homologous chromosomes so each cell ends up with a copy. So microtubules, which are these green lines, are anchored to centromeres and pull them apart. What else can we move around? How about carrying vesicles filled with proteins along an axon of a neuron? Now, as I mentioned before, there's a positive and a negative end, and you need a different motor protein depending which direction you're going. If you want to carry something towards the positive end, which is called anterograde transport, you can attach your cargo to a motor protein called kinesin, and if you're going towards the negative end, which is retrograde transport, you can use the motor protein dynein. In neurons, the positive end of the microtubule is at the distal end of the axon, whereas the minus end is near the cell body. So which motor protein is used to move something towards the synapse? That would be kinesin. And by the way, if you're moving a vesicle filled with proteins along the axon using kinesin, where were these proteins synthesized? If they're in a vesicle, then they were made in the rough endoplasmic reticulum, not in a free ribosome. And remember, in neurons, the rough ER is called the Nissl body. The last function of microtubules I want to cover is their role in cilia and flagella, but I'll save that for the next slide. First, let's go over some things that interfere with microtubules.
Alright, so why would you want to interfere with microtubules? Well, like I said earlier, one of their functions is in cell division, so anytime you want to block cell division, you can use a microtubule inhibitor. Some examples of microtubule inhibitors are drugs that treat cancer, gout, and parasitic infections. Cancer should be obvious here, since cancer cells divide a lot, but since immune system cells also require lots of cell division, microtubule inhibitors have kind of an immune suppressing effect too, which is why they can treat gout. And for the parasites and fungi, you want to use inhibitors that are specific to those types of species and have minimal effect on human microtubules. Some examples that are most likely to show up on step 1 are mebendazole, which treats helminths, griseofulvin, which treats fungi, colchicine, which is a super important drug which treats gout, and vincristine, vinblastine, and paclitaxel, which are all chemotherapy drugs. Now, why does colchicine treat gout? Well, first of all, what is gout? Basically, if you have high levels of uric acid in your blood, it will crystallize, and these uric acid crystals will deposit in joints, especially the big toe. This ultimately causes recurrent, acute inflammation. Alright, so what drug can you use to treat patients long-term for gout? That would be allopurinol, because allopurinol prevents uric acid formation. But during an acute attack, what do you use? So that would be colchicine, which doesn't affect uric acid directly, but is basically working as an anti-inflammatory drug, and you could also use NSAIDs or ice. Now for these chemo drugs, you learn more about these in the Hem-Onc chapter, but what do you think might be an important adverse effect of inhibiting microtubules with vincristine, vinblastine, or paclitaxel? These drugs can cause bone marrow suppression, since again we're preventing cell division. And like it says in your book, you can remember these with a mnemonic, microtubules get constructed very poorly. Alright, so what happens if microtubules aren't working properly? Well, it depends on the specific problem, but one example is called Chidia-Higashi syndrome. This is usually caused by a mutation in the lysosomal trafficking regulator gene, or LYST, which normally is required for organizing proteins into mature endosomes for microtubule-dependent transport. Since granulocytes need this to make their granules, this defect makes patients susceptible to recurrent pyogenic infections, since macrophages and neutrophils can't make the weapons they need to destroy bacteria. These patients also have albinism, since melanin can't be transported out of melanocytes, and peripheral neuropathy, since vital proteins can't be transported to the ends of long peripheral neurons.
So as I mentioned a minute ago, another role of microtubules is in cilia and flagella. Both cilia and flagella are made from microtubules arranged in a 9 dimers plus 2 singlets formation. So here I'm showing you an electron micrograph of a cross-section through cilia, and you can see the 9 dimers around the periphery and the 2 singlets in the middle. Now in the last slide I mentioned that dynein is used for retrograde transport along microtubules. Dynein can also be used to bind microtubules for a different purpose, which is to link these doublets together. Then ATP can be used to cause them to slide along each other, which makes the cilium bend. Flagella and cilia have a similar structure if you take a look at the cross-section, but they also have some functional differences. First of all, flagella move in this kind of propeller pattern, since they're trying to generate force that pushes the cell away from where it's pointed. Cilia beat back and forth, since they're trying to keep the fluid outside the cell moving in a consistent direction. Flagella are a lot more common in single-celled organisms like bacteria, but can you think of any human cells that have flagella? Sperm are the first ones that come to mind for me. How about cells that have cilia? Two important ones are cells in the lung, that keep mucus moving out of the lungs, and cells in the fallopian tubes, which move the egg towards the uterus. Okay, so what happens if you have an autosomal recessive defect in dynein? This is called Cartaginer syndrome, or primary ciliary dyskinesia, and if you have it, your cilia and flagella won't be able to move at all. So all these functions I just mentioned won't work. Both males and females will be infertile, since sperm can't move and the egg won't be pushed along the fallopian tube to the uterus. Patients with Cartaginers also commonly have bronchiectasis and recurrent sinusitis, since cilia are required to sweep particles out of the lungs. And lastly, it's associated with situs inversus, which is a condition in which major organs are found on the opposite side of the body. For example, the liver should be found on the right side, but here it's found on the left. Before we move on, let's see if you remember which direction these proteins go. Dynein is used for blank transport, and kinesin is used for blank transport. The options here, by the way, are either anterograde or retrograde. The answer is retrograde, or towards the minus end for dynein, and anterograde, or towards the positive end for kinesin. The plasma membrane separates the inside of the cell from the outside, and also is responsible for mediating interactions between cells. As you can see in this image, it's asymmetric, so one side may not look like the other. It's mostly composed of an even mixture of cholesterol and phospholipids, but also contains some sphingolipids, glycolipids, and proteins. Some proteins, like this one or this one, are transmembrane proteins, which means they have an intracellular, transmembrane, and extracellular part. These include transport proteins and ion channels, and receptor tyrosine kinases. There are also peripheral membrane proteins, such as phospholipase C, which are anchored to the membrane either by binding to another protein or a covalent bond to a membrane lipid. It's important to know that hydrophobic domains of proteins will always be found in the transmembrane region, since they're repelled by the water that is outside or inside the cell. Hydrophilic domains will be found bordering the cytosol, extracellular domain, or within the lumen of a transport protein. The sodium-potassium ATPase pump is a transmembrane protein that helps maintain physiologic concentrations of sodium and potassium in the cell. To do this, it utilizes active transport, which means it hydrolyzes ATP. Since ATP is produced inside the cell, it makes sense that the ATPase domain is on the cytosolic side of the protein. Remember, the inside of the cell has a lot of potassium and only a little bit of sodium, whereas the outside of the cell has a lot of sodium and only a little bit of potassium. Therefore, the role of the sodium-potassium pump is to bring potassium in and sodium out. For each ATP used, 3 sodiums are transported out of the cell and 2 potassiums are transported in. So let's say you have a cell and somehow shut down its sodium-potassium pump. Well, what's going to happen? First of all, sodium will start to accumulate inside the cell, since you're not pumping it out. And whenever sodium concentration increases anywhere, water is going to follow it. So the cell will swell and eventually lyse from osmotic stress. So this pump is really important in all cells, but there are some cell types that make their sodium-potassium pumps work really hard. Can you think of an example? One would be neurons, since every time an axon potential goes down a cell, they need to repolarize the cell. And a second one would be muscle, since even though they're dependent on calcium concentration for contraction, the sodium-calcium translocator uses the sodium gradient to remove calcium from the intracellular space, since sodium wants to flow into the cell, and you can use that energy to push calcium out. The sodium-calcium exchanger, by the way, does not use ATP. It just operates through passive transport. There are a few drugs that inhibit this pump. Wabane does this by binding to the potassium binding site, and is used as a poison by hunters in Somalia. Cardiac glycosides are drugs used for arrhythmias and congestive heart failure, and they include digoxin and digitoxin. These directly inhibit the ATPase part of the pump, which then causes sodium to build up inside the cell, which in turn causes the sodium-calcium exchanger to allow sodium to leave the cell. This ultimately increases the amount of calcium inside the cell. More calcium in cardiomyocytes means more cardiac contractility. Alright, time for another flash quiz. Let's see if you can remember those immunohistochemical stains for intermediate filaments. So what cell type is stained by desmin? And the answer to that one would be muscle. For the rest of this section, I'll be going over extracellular matrix proteins, which give tissue their structure. Collagen is the most abundant protein in the body, and it's made of 3 helical proteins that form a triple helix. There are 4 main types of collagen, which are different in the structures of the alpha helices that make up the triple helix. Each alpha chain can range from 600 to 3,000 amino acids, and the triple helices can be homotrimeric, which means they contain 3 identical alpha helices, or heterotrimeric, which means they have 3 different alpha chains. Type 1 collagen is the most abundant and is found in bone, skin, tendon, dentin, fascia, and the cornea, and is also involved in wound repair. Type 2 collagen is found in cartilage, the vitreous body, and the nucleus pulposus. For type 1, it's most important to remember that it's involved in bone, and you can remember this since the word bone has the word 1 in it. Similarly, type 2 is most important for its role in cartilage, which you can remember using the word cartilage. Alright, type 3 collagen is also known as reticulin, and is found in the skin, blood vessels, the uterus, fetal tissue, and granulation tissue. And lastly, type 4 collagen is found in the basement membranes, or the basal lamina, which you can remember using the mnemonic, type floor under the floor. Can you think of some places in the body where basement membranes are found? Important ones are the glomeruli of the kidney and the capsule of the lens. We'll talk more about that in a minute when we go through some associated diseases in more detail.
Most collagen synthesis takes place in cells called fibroblasts, which you can recognize by their spiky shape like the ones you see here. Let's take a look inside the fibroblast and go through the steps that lead to the final collagen molecule. Protein synthesis, hydroxylation, and glycosilation all take place inside the cell, and proteolytic processing and cross-linking takes place outside the cell. For the step 1, it's important to know a few things. Which steps take place in which subcellular compartments, the particular amino acids that are most common, and how they're modified. So you might have a question stem that describes a kid with a defect in collagen synthesis, and then they ask you, what's the most common amino acid in the protein that's defective? Do you know what that would be? The most common amino acid in collagen is glycine, and by the way, proline and lysine are the other 2 amino acids you should associate with collagen, since these are the sites of important post-translational modifications. So since this is a protein that will end up outside the cell, is it synthesized in ribosomes on the rough endoplasmic reticulum, or ribosomes floating around in the cytoplasm? That would be the rough ER ribosomes. So the first thing we'll make is the pre-pro collagen alpha chain, and then hydroxylation and glycosylation both take place in the ER. So here's another question you can get in your exam. Someone who's been sailing around the world and had limited access to fruits now has knee pain and bleeding gums. What step of collagen synthesis is not working properly? Well, this is a classic case of scurvy, or vitamin C deficiency, in which defective collagen makes you bleed, especially from your gums and also in your joints, which can cause joint pain. And which step in collagen synthesis requires vitamin C? Hydroxylation. Enzymes will hydroxylate prolines and lysines, and these hydroxyl groups will be used at the end of the whole process to link triple collagen fibers together, though I'll get back to that in a minute. The other modification in the ER is glycosylation, in which either a single glucose or galactose molecule is added, and this is only done in lysines. So why do you need to glycosylate your pre-pro collagen? Because these sugars allow the molecules to stick together to form procollagen and form a triple helix. And they're also held together by hydrogen bonds and disulfide cross bridges. A mutation that disrupts glycosylation and therefore prevents the triple helix from forming can cause osteogenesis imperfecta, which I'll talk about more in the next slide. Procollagen is then transported from the ER to the Golgi, and does that step require COP1 or COP2? That would be COP2, which is for anterograde transport. What happens to collagen once it's in the Golgi? Actually, not much happens in the Golgi at all. It's just used to transport the molecule out of the cell. So after exocytosis, procollagen is cleaved at both ends to make tripocollagen. It's cleaved at lysines in disulfide-rich regions of the protein, and then individual tripocollagen molecules are covalently bound together between lysines and hydroxylysines, which is catalyzed by the enzyme lysyl oxidase. What ion does lysyl oxidase need to be able to function? That would be copper, and by the way, lysyl oxidase is also needed to make elastin. This results in the final product, collagen fibrils. A deficiency in this last step is one of the important causes of Ehlers-Danlos syndrome, which I'll go over in a couple slides.
Osteogenesis imperfecta is one of the most common deficiencies in collagen synthesis, occurring in about 1 in 10,000 people. Therefore, it's also the most commonly tested. This is also called brittle bone disease, since it prevents the synthesis of type 1 collagen, which is a key component of bones. Since there are several different genes involved in collagen synthesis, there are a variety of genetic defects that can result in osteogenesis imperfecta. The most common viable form is autosomal dominant. Patients with OI can present with multiple bone fractures without a history of trauma, including during birth. This is often confused with child abuse, and you may have to differentiate between the two in your exam. Patients may also have blue sclera, since the connective tissue over the choroidal veins is more transparent, allowing the blue veins to be visible, which you can see in this image. Since the middle ear bones are required for hearing, Patients may have hearing loss as well, since those bones don't form properly. Lastly, patients have dental imperfections, since they can't synthesize dentin properly. And here's the last flash quiz for this section. What type of collagen is found in the basement membrane? Remember, type 4 under the floor, so type 4 is in the basement membrane. Collagen defects can also cause Ehlers-Danlos syndrome. There are several types of Ehlers-Danlos syndrome, all of which involve hyperextensible skin, which you can see in this image. The most common type is also known for having hypermobile joints, which you can see here. Some other types you should be aware of are the classical type, which is from a defect in type 5 collagen, and also comes with joint and skin symptoms, and the vascular type, which can come with easy bleeding or bruising, but also the more dangerous issue of barrianeurysms and organ rupture. This one is typically caused by a defect in type 3 collagen. Depending on the specific mutation, these can be either autosomal dominant or recessive. I wouldn't worry too much about the genetics or the type of collagen for Ehlers-Danlos, since there are so many different types with different etiologies, but you should be familiar enough with the symptoms that if you see hyperextensible skin in a question, and they're asking you what type of vascular pathology you should be concerned about, think of barrianeurysms. Next, we have Manx disease, which kind of indirectly affects collagen. Manx disease is caused by a defective gene called ATP7A on the X chromosome, so this is an X-linked recessive disease, and it's extremely rare, only affecting about 2 or 3 people out of a million. This gene codes for an ATP-dependent copper transporter, which is found in most tissues including the small intestine, where it helps absorb copper from the diet. So ultimately, this will look kind of like copper deficiency, and enzymes that require copper won't be able to work very well. So what's the enzyme in collagen synthesis that requires copper? I'll give you a hint. It's used to cross-link triple collagen triple helixes to make collagen fibrils. This would be lysyl oxidase, and this is why a defect in a copper-transporting protein causes collagen deficiency. The first signs and symptoms will be soon after birth, and you might see seizures, weak muscle tone, growth retardation, and blue sclera, like an Osteogenesis Imperfecta. And later, you'll see intellectual disability, and what is often described as kinky hair, although I would describe it as kind of a sparse and fuzzy-looking hair. You can actually treat this by injecting copper into the patient, although that only partially helps. Since this has an onset during infancy, it's important that you diagnose it and start treating as soon as possible to prevent the developmental problems. And the last thing to cover in the cellular section of biochem is elastin. As its name suggests, elastin is an elastic protein, and is found in anything that needs to be stretchy, like the skin, lungs, large arteries, elastic ligaments, and vocal cords. It's kind of similar to collagen in that they're both rich in proline and glycine, but it does not have hydroxyproline or hydroxylysine. It's also similar to collagen in that elastin is primarily produced by fibroblasts. So how is elastin made? Well, tropoelastin is secreted by fibroblasts and then cross-linked to other tropoelastin molecules along the scaffolding of fibrillin. It's the cross-linking of tropoelastin molecules that gives elastin its elastic properties. So what happens if you have a defective fibrillin gene? This is actually the cause of Marfan syndrome, which affects about 1 in 5,000 people. We'll come back to this later, but it results in bone elongation, arachnodactyly, hypermobile joints, lens dislocation, cardiac abnormalities, and aortic rupture. The most common cause of death from Marfan's is an aortic dissection, caused by cystic degeneration of the aorta, which you can see in this image. Now normally, elastin is broken down by the enzyme elastase. To prevent elastase from breaking down too much elastin, the protein alpha-1 antitrypsin inhibits elastase, thus preserving elastin. If a patient has a deficiency in alpha-1 antitrypsin, elastase becomes overactive and destroys elastin. This is often due to a lack of alpha-1 antitrypsin secretion from the liver, where its accumulation can cause cirrhosis. This also creates a problem in the alveoli of the lung, where lack of elastin results in emphysema, especially in patients who smoke cigarettes, since cigarette smoke also inhibits alpha-1 antitrypsin. In this image, you can see normal alveoli on the right, and alveoli damaged by elastase on the left, which is what emphysema looks like. A common treatment of alpha-1 antitrypsin deficiency is intravenous infusion of alpha-1 antitrypsin, and interestingly, this also helps patients who have emphysema from smoking. Alright, let's go through a couple questions before moving on to the next section. We'll start with this one. A young father brings his 16-month-old son to the emergency department for the 3rd time in 6 months. The toddler has a non-healing wound in his right knee that originated after a fall 10 days ago. According to the father, the previous clinical visits also resulted from falls in which the child incurred multiple broken bones in his wrist and tibia. Physical examination reveals blue sclera and an abnormal posture. It is noted that the child does not react to conversation. Which of the following is the underlying factor in this child's diagnosis? So go ahead and pause the video if you want some time to think about this. Okay, so what's going on here? Well, you've got a kid who's repeatedly breaking bones, which can either mean one of two things. He's being abused, or his bones are easily breakable. The giveaway here is the blue sclera, which you would not see in child abuse, but you do see in a certain disease that makes you prone to breaking bones. In fact, it has the nickname brittle bone disease. So the answer here is choice D, a defect in type 1 collagen, which is Osteogenesis Imperfecta. Remember, type 1 collagen is the type you should associate with bones. And by the way, how does the child not responding to conversation tie into this? Well, remember, there are bones in your ears that you need to hear, so this is in reference to the hearing deficiency that comes with Osteogenesis Imperfecta. Okay, let's do one more question before moving on. So, a 53-year-old man presents to a clinic for the first time. He has not seen a doctor in years until a few months ago, when he presented to the emergency department with severe headaches, and underwent life-saving brain surgery. On examination, you notice he has flexible joints and compliant skin, as well as an abundance of bruises all over his body. When asked, he says these things run in the family, but have never caused him any problem. What defect is most likely contributing to this patient's disease process? So again, you can go ahead and pause the video if you want to think about this. Okay, so this guy has hyperextensible skin and hypermobile joints. That narrows it down really quickly to Ehlers-Danlos syndrome, which is caused by a defect in what? Well, that's actually a tricky one because there's a lot of different types of Ehlers-Danlos, caused by defects in different types of collagen. So now we need another clue from the question, which is his life-saving brain surgery. Why would someone with Ehlers-Danlos need brain surgery to save their life? A berry aneurysm, which you're going to see in the vascular type, and this is caused by a defect in collagen type 3. Now, another noteworthy guess would be that he had Marfan syndrome, which is a defect in fibrillin, because that also comes with hypermobile joints and berry aneurysms, but you wouldn't see hyperextensible skin with Marfan, and they would also probably give some more Marfan-specific signs, like tall and thin with long thin fingers.